want you to completely relax for me, okay? Okay, from this position, I want you to go ahead and turn your head to the right for me. My thumb.
Where are your right fingers?
Okay, it's over the C5, C6 vertebrae on the right side. Okay, relax. I'm gonna bring her up in a little bit. Okay, right there. Go ahead and look again. Okay, good. All right. Now let's go back to our translations again. We're here, C5 on C6. Okay, not 1,000% better, but about 25%. So I'll take that as a win. I can always come in and do some muscle energy. Go ahead and lift your shoulder towards your ear. Relax. A little bit more. I lift again. Lift, 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 relax. And one more. Lift, 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 relax. Okay. Is that a painful stretch or is that just a big comfortable stretch? Okay, so if I was going to give her one corrective for home, what would I probably give her? Or two? Excellent. Upper trap stretch. And what else? Exactly. Cervical retractions, chin tucks. So I've addressed what I see is tightness in suboccipitals, even though it's not painful, and I see that posture that she presented with. So I'm going to work on getting her normal alignment back in, and then I want to follow that up with some muscle flexibility, focusing on that upper trap, levator. What would be one more totally appropriate muscle to add into that as a good stretch?
Or the deep neck.
Pec minor, pec major. And why? Those rounded shoulders. So can I have you sit up for me? So let's just look. I'm just going to look at range of motion. So can we look at extension? Okay, so the hinging's not as bad, so that's good. How about flexion? But she still hinges. So we want to address that. Okay, how about right and left rotation? So from midline. Okay, a little further, but she's still got that compensatory shoulder hike. And then how about side bending? Okay, and a little improvement, but not where I'd be happy for her to go home. So I want to treat that a little bit more. So any questions about that at all? Yes, sir.
When you were on C5, C6, where was she pushing?
She's pushing into right side bending rotation. And we're going to go through all that. I just wanted to show you how we can do something very quickly, impact change, get her a home exercise program, and I'm still at 37 minutes.
If you were to continue, you said you wouldn't want her to go home yet. If you were to continue treating it, would you stick with muscle energy or would you try a different technique since it was only a little bit?
So you can try a lot of different things. So I think because she's not in a lot of pain, I mean 3 is medium, moderate, so I think it'd be appropriate to start with muscle energy, and that's really safe in the C-spine. If she was open to it, looking at an up glide manipulation or down glide for C5 on C6, I think would be appropriate because you'd be addressing the articular limitation that's there. We can see that in extension, probably more closing than opening, because that's what the lateral translation assessment correlated to in terms of her loss of extension and loss of side bending and rotation. Dry needling, I use a fair amount of that in practice, so addressing that upper trap tension in a very direct, quick way. What else? What are some other interventions I could use? Would cervical traction be appropriate?
No.
Why not?
There's no radiculopathy.
Okay, there's no radicular signs, so I wouldn't use cervical traction for her. Now I use cervical manual distraction a fair amount. That's just partially that a patient will get used to my hands. It helps them relax a little bit. It may alleviate some pain. What else? Okay, suboccipital release, other soft tissue, myofascial release, scalenes, upper trap, levator, all things that we'll go through next week. Anything else you guys can think of? Did I mention any modalities? No. Not that it's not appropriate, I just don't use a lot of modalities in practice. 3 out of 10, the patient reports that heat makes them feel better, and that's gonna increase the value of buy-in to the patient. I'll put a heating pad on her for 10 minutes and let her relax with that. There's nothing wrong with that. As long as I'm not creating passive dependency on some sort of modality. I wouldn't use ultrasounds. Evidence is really bad for that. If her pain was a lot higher, I might look at E-stim or a combination of needling and E-stim. Just to get that modulation effect, get that pain under control. But 3 out of 10, I'm really not as concerned. I think I can impact that more through manual therapy than I can through use of modalities. Other questions at all? Yes, sir.
Do you ever look at acid for maybe being cause of cervical?
look at, I'm sorry.
Thoracic, address.
Absolutely. So you can look at T-spine mobility. That would be another appropriate. So I can look at her overall T-spine mobility. Can you cross your arms across here? And this is where, depending on the amount of time, so I'll usually come to like mid T-spine, go ahead and extend your upper back. Okay, and look, does she have the available mobility? She does. She's a little tight, a little hypomobile. You can feel that just as she extends, she's really arching back. So thoracic manipulation would be totally appropriate. Either what I call, we'll learn the summer camp manip, or a supine technique that's really effective at decreasing that. So that's great. And you don't have to do everything on day one. You want to try to get as much information. I guarantee you that next visit, we would start looking at other contributing factors, because there's just not enough time to look at everything on visit one, but that's a great point of something that you want to look at in addition to the C-spine. Because what does Dr. Holmes always say? The body is a sausage link. So you always have to look at the contributing factors. I think it would be appropriate to look at neural tension. Even though she doesn't have symptoms, this sort of posture lends itself to adverse neural tension. So maybe as we get towards visit 2, visit 3, adding in tensioners and sliders as part of her clinic or home program would be appropriate to prevent the onset of adverse neural tension.
What kind of things are you going to address for her to like fix her posture? Like, what all are you going to tell her to do?
Okay, so what are some things that I could do for posture re-education? Okay, I can look at ways to support. So that's where things like KT tape, duct tape, no, not duct tape, KT tape, Luca tape can be really effective. We'll go through postural taping with Luca tape, McConnell taping for the scapula because it's a lot more rigid. So I can reinforce it through that because anytime she slouches, it's going to be uncomfortable. I'll taper her in retraction. What else? Okay, anecdotal evidence from my own practice. They do have those posture straps that work moderately. There's a clavicular strap for clavicular fractures that pulls someone's shoulders back to decrease some stress on that, and those have worked. What's the most important variable for success with posture re-education? Okay, proper technique, but patient compliance and patient adherence. Okay, they have to have buy-in. They have to see the value in improving their posture. Or you can put all the tape in the world that you want, it's not going to be reinforced. So I like to pictures. Okay, ask them if you can borrow.